All right. Well, good afternoon, everyone. My name is Amanda Tyholsky, and my pronouns are she, her, with the University Hospital's Clinical Research Center. And thank you all for joining us today for our Discover with UH webinar series. We're very excited to be joined by two of our esteemed physician scientists who will be talking with you and with us about their work. Today, we've asked Dr. Pope and Dr. Kelly to share with us some of the recent research within the LGBTQ plus community. So I'm going to start by introducing Dr. Pope. Dr. Pope is a gynecologist with fellowship training in global women's health. She is the chief of female sexual health division and part of the gender care program in the Urology Institute at University Hospital's Cleveland Medical Center. Her clinical practice surrounds female sexual health, birth injuries, cancer survivorship, vaginal reconstruction, and gender affirming surgery. And her research interests are in health disparities and social determinants of health. She has authored over 40 peer-reviewed manuscripts and is always engaged in research to improve cis women's and trans women's sexual and gynecological health and to improve access to high-quality healthcare worldwide. So everyone, please welcome Dr. Pope.
Thank you so much, and it's my pleasure to be here and to speak briefly to you all. So I'm going to just share my screen. Give me a second to get that set up. All right, is that showing up okay? Okay, great.
Yes,
all right, so as I said, it's my pleasure to be able to speak on this topic. I'm by no means an expert. I feel like in research, we're all learners. Curiosity is what brings us here, and wanting to impact some sort of change is what keeps us in this field. So I would love to just share a little bit of what my experience has been. So many people have asked me, why am I interested in specifically transgender and gender diverse research and surgery? And really, I come to this as a gynecological surgeon with a background in global health. So I did a residency in OBGYN here at UH actually. And then when I did my fellowship, I was in Malawi in sub-Saharan Africa. And there I was taking care of cis women who had birth injuries that caused a hole essentially through their bladder and their vagina and sometimes through their rectum. So they were incontinent from urine and sometimes feces. And what I found with that population was these injuries happened to them because they were already in an impoverished state and somewhat marginalized because of that poverty, where they didn't have access to high quality obstetric care. And then what kept them in that state was the perpetuation of their lack of access to medical and surgical care. And I really found that my calling was to be a social justice advocate for those women by performing surgeries for them and getting them that care. So when I came back to the US, my family returned to Cleveland, and I came across this other group of marginalized folks who actually could benefit from surgery. And seeing how surgery could be a tool for social justice was just really, sat well with me and excited me. So as I got to know this population more and worked with them more, I realized that there really are many aspects that affect their medical care and their well-being, and things that we could prevent and make better for them through healthcare. So to give you a little bit of background about the gender diverse and transgender population in the US, the current estimates from the CDC is that about 0.5% of the US population identifies as transgender, which equates to about 1.5 million people in the US. This population is unfortunately marginalized in many of our communities, and I think we are making steps to become more inclusive. But the reality is that from this large survey that was sent to 27,000 individuals who identified as transgender or gender diverse, 26% of them lived in poverty. Their unemployment rate was 3 times higher than the overall population of the US. And only 16% of them actually owned a home compared to 63% of the US population. 30% of them had experienced homelessness at some point in their lives. And these percentages are even higher for trans people of color, trans people with disabilities, and undocumented trans people. We see that discrimination experienced in this population leads to all of these social determinants of health. And unfortunately, as I mentioned before, translates to their healthcare access. And through every research paper you can find, you'll find the barriers to access to care. And so we know that 19% of trans patients report being refused healthcare for their gender specifically, and 33%, so 1 in 3, experience a negative experience with a healthcare provider, just a one-on-one interaction. 25% experience a delayed care because of disrespect or discrimination that they experience. And 48% really see that this impacts their access and delays their access to care, maybe because of insufficient funds, but also because of the discrimination that they are experiencing. So we know that trans patients are more likely than cis patients to lack healthcare coverage, to not identify a primary care provider that they see regularly or that they could trust, and to report poor general health. Now, not all trans individuals want surgery for gender affirmation, but psychologically, and I think my colleague Dr. Kelly is going to speak to this, we see that surgery does benefit many individuals who are experiencing gender dysphoria. And we see day to day with our patients that when they want surgery and they access it, that it's life-changing for them. However, if there's a barrier to access of medical care, then how do we know how many people actually want surgery and just aren't getting through the front door? And this is what led me to my research question. So this has been a joint collaboration with the LGBT Community Center, which I think has been key in studying and asking these questions and trying to get accurate answers. But it's funded by the Center for Reducing Health Disparities from Metro Health. It's funded through the NIH, and our collaboration is called Advocate. It's the advancement of care for transgender and gender diverse people. This is our team, which is a very exciting, very talented group of people I've had the pleasure to work with for the last year. Braveheart Jelani is a doctoral student in the Mandel School at Case. Daniel Hamilton is a doctoral student in the anthropology department at Case. Gulnar Farista, she's the director of programs at the LGBT Community Center. Dr. Shubham Gupta, who's our director of the Gender Care Program and our chief of the Urology Reconstructive Division. Dr. Erica Kelly, who you'll hear from momentarily, an adult psychologist, and Dr. Swagata Banik, who's based at Baldwin Wallace University and is the Dean of Graduate Studies and Research there and has extensive experience studying the trans population internationally. So this team basically worked with me for the last year to develop the methodology and actually go through the research step by step. We decided as a group that we hypothesized that there are individual sociocultural and structural barriers to both hormone therapy and surgical care that would alleviate gender dysphoria for trans individuals, similar to the barriers that they experience from standard medical care. We decided to go to the community and talk to them directly. And this has been what's been so rewarding about studying or doing this research project specifically, that we set up a series of focus group discussions with community members who identified as transgender and gender diverse. And then we also had focus group discussions all via Zoom because this was during the pandemic, and it made it possible for people to be able to join from wherever they were based. And we interviewed individuals who had had surgery with us for gender affirmation and had already gone through the process, because we wanted to find out, what did they experience along the way? What were the barriers and what were the things that actually helped them overcome those barriers, if there were any? We also formed a community advisory board. As you saw in the beginning of this presentation, community advisory boards are part and parcel of research when you really want to impact change. And this has been such a pleasure to work with the community advisory board, who helped us from the very beginning decide what questions to ask our focus group, what they felt like would be the most important, and then interpret the results alongside of us, because I think all of us are coming from a different perspective. So having those who are living day in and day out this life and experiencing some of the discrimination that we suspect our patients are experiencing is extremely helpful to have that insight. And then we've been going through the focus group discussions to pull out themes and understand what some of the most common experiences have been. Then using those themes, we crafted a larger statewide survey that's sent out electronically so that we really could capture a larger population of trans individuals and those who identify as gender diverse, and ask them what their experiences have been encountering medical and surgical care. I'd love to share with you some of our preliminary findings. We have found that navigating health insurance is a major barrier. I think anyone who has had major surgery or multiple surgeries can see how difficult it is for anyone to work through insurance sometimes if they don't want to cover something, or if the diagnosis has to be cemented in, or everyone has to call insurance and make sure things are covered. But our research participants told us that even if they had insurance that was supposed to cover gender affirming procedures, when they would try to get them, sometimes they would be denied. And when they would call in their insurance companies, they would experience discrimination. They experienced misgendering, they experienced mocking, and people just being insensitive and just outright rude to them. So I think all of us could empathize that if we're on the phone trying to work through coverage of a surgical procedure that's going to help us live our day-to-day life in a more functioning manner, and then experiencing discrimination on the other side of the phone, and just to get that first coverage and make sure that you're not going to end up with a huge hospital bill, it's very challenging. They also identified that there is this medical gatekeeping, and we use a World Professional Association of Transgender Health Care standards, which the insurance companies often require. And the idea is honestly to help ensure that there aren't psychiatric issues that are not being addressed, to make sure that everything is going okay with gender affirming hormones before moving towards more definitive surgery. But it really can be a series of hoops that we're requiring our patients to jump through. And again, as you saw from the beginning of the procedure, there's so many difficulties with access to general medical care, discrimination experienced at the workplace, and throughout life, that adding these additional hoops really just makes it more challenging for everyone. Several of our participants mentioned having to educate their providers, which as a provider myself is extremely embarrassing, but hearing that they have to tell their primary care physician or their gynecologist what it means to be trans and what kind of things that they need from them for their healthcare, what kind of tests they might need to do, what kind of imaging, and how to actually access hormone therapy. And that some of our patients or some individuals, throughout the region will have to travel long distances to find someone who's actually educated and trained in providing hormone or surgical care. And then unfortunately, the stigma and discrimination that individuals feel translates not only from the healthcare provider's office, but throughout the waiting rooms. While they encounter front desk people, and they can be misgendered, or they could be called by the incorrect names. And then when sometimes just dealing with ancillary staff in labs and radiology, everywhere they go, unfortunately, there are negative experiences that we heard about through the focus groups specifically. Lastly, coordinating care between multiple care providers, multiple surgeons, multiple healthcare providers can be really challenging, and additional hoops that these individuals have to jump through in order to get their care that's going to greatly improve their life. I do feel really fortunate that at UH we have LGBTQ plus and gender care services. So I feel like as we are learning these difficult stories about discrimination that our patients have experienced and our community members have experienced, we actually can make a direct impact and make a change. And working with our team, really finding creative ways to make a difference is really inspirational. And that's why I think research is so important. It helps us to identify what the issues are and make things better for people. So I'm so grateful to Tina Reed and the rest of our program and on their gender care services. So I'd like to thank you for your time. Thanks for letting me give you that brief overview. And thanks to all of our research participants, our patients and funders and supporters, the IRB office, the CRU, Center for Reducing Health Disparities, and the Urology Institute that have supported this work that we're still undertaking and grateful to be able to share some of our preliminary findings with you. And really, we do just hope to impart improved care through research. And I think it's possible, and this is what actually can affect change. So I'll just close with that.
All right, thank you so much, Dr. Pope. It's really because of you and all your community-based research and your previous experience, and really identifying these barriers in the healthcare system and in this community that doctors like you and Dr. Kelly can really begin, to break down these tough barriers and work to provide an easy, inclusive, and comfortable environment for everybody to receive easy and accessible care. So that is great. And thank you so much for presenting your research. So our second panelist today is Dr. Kelly. Erica Kelly is a PhD, is a clinical psychologist in the departments of OBGYN, the Division of Behavioral Medicine, and Urology at University Hospitals, and is assistant professor in the departments of Reproductive Biology and the Urology Institute at Case Western. She completed a postdoctoral fellowship in women's health and aging and PTSD at Stanford University and the VA Palo Alto Healthcare System. She currently serves as a co-chair for the American Society for Reproductive Medicine's Mental Health Practitioners Group Scientific Development Committee and is a senior consulting editor for the journal Psychology of Violence. Her areas of research interest focus on the intersection of women's physical, mental, and sexual health across the lifespan, with a particular emphasis on the role of trauma and the identification and reduction of barriers to healthcare in the transgender and gender diverse individuals. Dr. Kelly will be sharing her work today on mental health in the LGBTQ community. So please join me in welcoming Dr. Kelly. Dr. Kelly, the floor is yours.
Thank you. Let me see if I can pull up my slides. Always an adventure. Okay. So I am very delighted to be here today, especially speaking after Dr. Pope, who does wonderful work in clinical work, research, and advocacy. I will be speaking on the behavioral health side. So I'll describe a little bit about what we know from research in terms of behavioral health and barriers to care among transgender and gender diverse individuals. I have no disclosures, but I would like to express my appreciation to my community partner, our community partner, the LGBT Community Center of Greater Cleveland, alongside Gulnar Farista, who Dr. Pope mentioned, members of the transgender community, our participants and patients, as well as the Center for Reducing Health Disparities, who also fund my research, alongside my colleagues, including Drs. Kingsburg, Castor, Pope, Gupta, and Bannock, and this is among others. It truly takes a team to do wonderful research and clinical care that we do. I would like to mention that throughout my talk, you'll probably notice I use the terminology of TGGD in the slides. That's just to refer to transgender and gender diverse individuals. I'm going to briefly talk about mental health disparities among transgender individuals, just to give you a snapshot of that. And also, I'm a psychologist, so this is very close to my heart to talk about it. I want to take a moment to talk about gender dysphoria. Hopefully we're all familiar with what gender dysphoria is, but I have on the slide here what you would see as criteria in the American Psychiatric Association Diagnostic Manual. Gender dysphoria refers primarily to a marked incongruence between one's expressed or experienced gender and their assigned gender or their sex assigned at birth. So this can manifest in a lot of different ways. For example, the individual may have a strong desire to be rid of their primary or secondary sex characteristics because of that incongruence between their expressed experienced gender and their sex assigned at birth. And this incongruence is accompanied by significant distress and impairment. So I mention this because I think it's so important for clinicians, researchers, really everyone to know that it's not pathologic to have a gender identity that is different from cisgender, but it's really the distress that's related to the discrepancy that we are wanting to address in treatment among transgender individuals. I won't go into too much detail. I'm putting some examples for you of the mental health disparities that are experienced among transgender individuals. For example, we see rates of depression at least 5 times the rate compared with the general population in transgender individuals. So it just speaks to the importance of improving mental health in transgender and gender diverse individuals. We also know that transgender individuals are at increased risk for exposure to violence and discrimination. And at this point, we consider it a national epidemic of violence against transgender individuals. You would expect close to 100% of transgender individuals will experience violence, including discrimination-based violence. As Dr. Pope mentioned, this unfortunately will also include healthcare-related discrimination. And we know that this exposure to violence and discrimination is one of the reasons why we see increased rates of mental health and physical health conditions among transgender individuals. Also, as Dr. Pope mentioned, really providing gender affirming care is incredibly important for transgender and gender diverse individuals. What we see in research is that conversion therapy or any attempt to change one's gender identity or sexual orientation, so to try to make a transgender individual cisgender, is incredibly harmful, even though unfortunately it is still experienced in the US. And so what we want to do is promote better health among transgender individuals and address that distress related to discordance between sex assigned at birth and expressed gender. So gender affirming care can mean a lot of different things. It can mean gender affirming medical interventions that Dr. Pope mentioned, so hormone therapy or bottom or top surgery, but it's also important to address the mental health conditions that are experienced at higher rates among transgender individuals. The other thing I want to mention is as part of really good healthcare, when someone is seeking the gender affirming medical interventions like hormone therapy or surgery, we want to make sure that we are providing adequate support and counseling and allowing an individual to make informed decisions about their own healthcare and feel empowered and autonomous in their healthcare. I will make the same plug that Dr. Pope did. We are very fortunate to have our gender care services here at UH. I'm also including, just for reference, the scheduling line. For us, we have 3 psychologists in the behavioral health division, OB/GYN department. So please feel free to reach out for us for support. So I want to spend a little bit more time talking about health disparities to lay more of the groundwork for my current research. There are a lot of different barriers, as Dr. Pope also mentioned, to healthcare for transgender individuals. So for example, you see in the bottom right corner, history of and fear of discrimination in the healthcare setting if an individual discloses their transgender identity. There are also provider-based barriers, so lack of knowledge of appropriate care or provider binary assumptions to care. That will leave gaps in healthcare among transgender individuals. I won't share all of these with you, but I just wanted to show you a couple of example quotes from a qualitative study by Hines and colleagues that just, I think, highlight the impact of these healthcare disparities and discrimination among transgender individuals. So the top right one, you can see an example of a transgender individual seeking mental health care. Their psychiatrist said to them, "I don't know how to deal with this. I've never dealt with anyone like this before. I'm going to put you back in the system so that you can find a new doctor." So you could see where this would lead to delay in care, if nothing else, for this individual. And so just highlighting here the importance of this kind of research and supporting healthcare needs among transgender individuals. I want to highlight a couple of barriers to healthcare disparities among transgender individuals that are most relevant to the research that I will share with you today. The first is that some healthcare procedures may involve sex characteristics that can trigger gender dysphoric distress. So for example, if a trans male needs to receive a pelvic exam and a pap smear, that may trigger the reminder of their sex assigned at birth and trigger gender dysphoric distress. And so that can lead to some avoidance in healthcare or significant distress in the context of healthcare. We also know that certain healthcare procedures may mean that an individual has to delay their gender affirming treatment. So for example, if someone is seeking bottom surgery and they are counseled that surgery may impact their fertility, if they want to undergo fertility preservation, so for example, egg freezing or sperm freezing, that might mean that they have to delay their gender affirming treatment or their surgery to get the fertility preservation first. And so that delay in the gender affirming treatment may cause significant distress. This is also important to highlight because we know in research that transgender individuals are primarily likely to seek healthcare when it involves gender affirming treatment or care, hormone therapy or surgery. So they may be less likely to encounter or access primary care services. And then finally, the other relevant barrier to my research is that really there's a lack of or difficult to access amount of information regarding the healthcare needs that's truly inclusive to transgender and gender diverse individuals. So one aspect or one concept that's very important to the research that I'm conducting is this concept of shared decision-making. This is crucial to client-centered healthcare. Shared decision-making means collaboration between a healthcare provider and a patient or client, and that this shared decision-making model is meant to foster client empowerment in their healthcare, help them make informed decisions, and help with communication between a client and patient or the providers. There are a lot of different forms of what we call shared decision aids, or these are tools that help facilitate shared decision-making about healthcare. So for example, these could be brochures or online interactive tools that someone can look at, different options about surgery, for example, the risks and benefits of each option. Often shared decision aids will include a values clarification exercise where the client or patient identifies what are their most important values, and that can help them make an informed decision about the best healthcare option for them personally. Hopefully, by understanding some of the barriers, you can see where there are unique facets of shared decision-making among transgender and gender diverse individuals. So, for example, the information about certain healthcare services might be lacking or not tailored to this population. Individuals may have experienced discrimination and stigma in their healthcare, and so a healthcare setting might not really feel like a safe space to have these conversations about healthcare. And we know in research that transgender individuals historically have been filling in the gaps of their own healthcare by looking to their peers for information or support in informing their decisions about healthcare, and less likely to seek out information from their healthcare providers. So again, I'm sort of highlighting the importance of shared decision-making and improving access to healthcare among transgender individuals. So to explain a little bit about my current research, now that hopefully I've set the stage for some of the background, the overall aim of my research in this area is similar to Dr. Pope. It's to reduce barriers to healthcare among transgender individuals, and primarily by improving decision support for individuals, especially in the context of experiencing stigma and discrimination in healthcare and lack of information about healthcare that is inclusive, as well as reducing distress related to gender dysphoria that might come up in the context of healthcare and distress related to discrimination. I wanted to describe a little bit about the community-based participatory research approach. That is an approach that I'm using to inform my research, and I know it's also relevant to Dr. Pope's research as well. I encourage you, if you are not familiar with this, to look into it a little bit more. It's very informative and helpful when doing any research around marginalized communities or stigmatized or discriminated communities who experience discrimination and barriers to healthcare. So community-based participatory research is really meant to be a collaboration across different stakeholders in research. So this will include collaboration between a researcher like myself, as well as members of the community and community agencies or organizations that are important to consider. So for us, this would be involving members of the transgender and gender diverse community and the LGBT Community Center of Greater Cleveland at every single stage of the research, and keeping open communication and making sure that we are meeting the needs of the community and including their voice across research. And we want to be mindful about dissemination of our findings in a way that not only, results in a publication, but also really truly promotes change in healthcare, increases health equity and social justice. So very briefly, I will describe to you my current study that is just getting started. So this study is about about improving cancer screening uptake among transgender individuals. So we know that among transgender individuals, cancer is really the least commonly researched global burden of disease initiatives. We see some research indicating poorer cancer health outcomes among transgender individuals. This is not because of their gender identity, but it is more likely that it's related to the barriers to healthcare and discrimination experienced by transgender individuals. We also know that transgender individuals tend to seek information from their peers or online, including via social media, to inform their healthcare decision-making. And again, to highlight barriers to cancer screening among transgender individuals, cancer screening procedures can involve primary and secondary, sex characteristics that could remind the individual of their sex assigned at birth and trigger distress related to gender dysphoria. And we also know that we have a lack of really clear guidelines related to cancer screening specifically tailored to the needs among transgender individuals. So the title of this study is Role of Social Media in Cancer Screening Uptake in Transgender and Gender Diverse Individuals. And our main aim is to see if we can leverage social media platforms in developing shared decision aids to improve cancer screening uptake among transgender individuals. As I mentioned at the beginning of my talk, the study is funded by the Center for Reducing Health Disparities. And I also recommend that you take a look at their webpage. There's a lot of useful information about community-based participatory research. And I will just briefly touch on my aims because I know this is a very wordy slide, but there are several sub-aims of this study. This is really the early stages of research in this area. So what we want to do is conduct in-depth interviews among transgender individuals to get a better understanding of their attitudes and knowledge towards several different cancer types. We want to better understand what information do they seek about cancer preventive care and what is necessary for them in their decision-making related to whether or not to seek cancer screening. We will also conduct in-depth interviews with healthcare providers to understand their perspectives about the potential role of social media platforms in developing a shared decision-making aid to improve cancer screening in transgender individuals. And then we will conduct a larger survey to better understand transgender individuals' interests and needs regarding social media-based platform for shared decision-making to improve cancer screening. And in the long run, we hope that the results of this study will help us inform the development of an actual shared decision-making aid via social media to increase cancer screening uptake in transgender and gender diverse individuals. So unlike Dr. Pope, I don't have any preliminary data to share with you yet because we really just got the funding very recently and are just starting to get this research up and running, but I'm very excited to see the outcome. So I think that's all I have for you. Thank you so much again.
Dr. Kelly, thank you so much for your presentation. I think we all know how important it is for everyone to receive their cancer screenings and for preventative care. And hopefully your research that you're currently doing and in the future will really reduce the barriers to screening in the transgender and gender diverse community. So thank you very much for that. And it looks like both of our presenters already have their videos on. So for those of you in attendance, it is the kind of research and work that Dr. Pope and Dr. Kelly are doing that really add to the UH's rich 150-year history of research and innovation. So now, if you have any questions for Dr. Pope or Dr. Kelly, please feel free to type those into the Q&A module at the bottom of your screen, and we will take a look at those for them to answer. So Dr. Pope and Dr. Kelly, we're going to ask you a few more questions about your research. So when doctors choose a specialty, and as both of you have, they really have a passion for it and the research that goes along with achieving breakthroughs in those areas. So really the first question that I have for you is, what led you to become interested and involved in clinical research in the LGBTQ community? Dr. Pope, if you would like to start that off for us, that would be
Sure.
great.
Yeah, I mean, I think it's something that is necessary at this point. I feel like we've been excluding these populations for a very long time, even if it was not intentional. I think we have been. And so for those of us who are in women's health is often primary care. We need to be more inclusive. And as I kind of mentioned in my presentation, I feel like researchers tend to be very curious people. And when we start to recognize patterns and see that there are things happening where we need more answers, that's when we come up with research questions. So I feel like it was by necessity, realizing that this is a population that's underserved, and I had a lot of questions and a lot of interest in wanting to make things better for this population. And so that's kind of what led me there.
Great, thank you. And Dr. Kelly?
I love your comment, Dr. Pope, about just the necessity at this point. I would agree with that. My interest really started in undergraduate training. A lot of my earlier research was on violence, interpersonal abuse, and the impact of violence and discrimination just broadly. And it started mainly in the area of violence against women, but I started to understand more about the impact of violence and discrimination among individuals in the LGBTQ community. I remember, this probably was 10 years ago, I remember with a colleague, we were trying to publish results from a study on violence, and we wanted to include a subgroup of individuals who identified as transgender, and it was denied publication because they said it was just too controversial at the time to publish, and the numbers were too small, and we needed to completely exclude them from our data set. And so just kind of understanding the impact of that and how that contributes more to being contributes to overall discrimination and lack of inclusion was very impactful for me. And so I, from that point, became more and more interested in this area over time.
All right, great. I think you touched on some great topics of that really in this day. It's needed. So thank you guys very much for understanding that is really needed. So throughout the presentation, I really addressed the term LGBTQ plus and being inclusive of both gender and sexuality identity. So just quick, for those who may be unfamiliar with terms like cis or transgender, non-binary, bisexual, asexual, and pansexual. For those, again, who may not be familiar, can you just give us a brief overview of what all of that means for everybody's knowledge? Dr. Kelly, Dr. Pope,
Go ahead. No, go ahead. If Dr. Kelly, I would be happy for her too.
I was just going to say, if it's okay if I share my screen.
Yeah, that'd be great.
Absolutely.
Sorry, there we go. If you're not familiar with this, I highly recommend taking a look at the gender unicorn. This is a great way of communicating terminology. Sorry, I'm having trouble I can't see the audience here, and I don't want to block the slide. But Dr. Pope, please feel free to chime in here. But gender identity is your experienced gender. It may not match what is your sex assigned at birth. So if you were natally described as female, you may not identify with that. And so it's truly your internal experience of gender. Gender expression is how you really socially or externally express your gender. So this could be through clothing, for example, communication, really how you present in terms of gender expression. I don't know if there's more terminology that we want to go over in particular, but I really do recommend taking a look at transstudent.org. They have a ton of great information just on better understanding terminology. So Dr. Pope, I don't know if you want to.
Yeah, the only thing I would also add is, we always say LGBTQ plus, and I think that makes people almost assume that gender and sexuality are one and the same, but they really are different, as the slide is showing there with, by Dr. Kelly. And I'm glad you had that slide. That's such a great explanation, and tries to simplify things, I think, in a way that's helpful. So I think it's important to just remember gender is not necessarily describing someone's sexuality, and we can never make assumptions about one's sexuality. And most of the time sexuality does not matter for what we do, but gender expression might, and really just being sensitive to that, I think, is important.
And I would, yes, just to add on to that, I would clarify sexual orientation as who you're physically or sexually attracted to. And I think the Dr. Pope's point, it's very important to distinguish between gender identity and sexual orientation. Those are not the same thing. And we don't want to make inaccurate assumptions.
Perfect. Great. Thank you, Dr. Kelly, so much for that, that website as well. I think all of us can take a look at that and see, take a really deep look into that and see, really be able to distinguish. So kind of going along with that, in sexuality and gender, we actually had a question in the Q&A module. So here we talk a lot about clinical training and what we do for the LGBTQ plus community and care for more inclusivity. Can you just comment on maybe some of the things that we're doing or that we could do with the infrastructure here at UH or in your practice side of things to kind of address the continuity of care for those who potentially, be misgendered or misnamed, and have multiple MRNs in the ER just based on their gender or their sex at birth? Dr. Pope, I'll let you kick it off.
Sure. Yeah, I think using the EMR to our benefit really needs to be done. And I think, as the Jennifer McLeod put in the Q&A, there are opportunities to do that with our current EMR. And we should be taking advantage of that to really enhance the care. And that's what electronic medical records should be doing. They should be making things better for everyone, both the people who are using them and the patients that we're seeing. So I do think we need to find ways to take better advantage of that and make it easier for everyone. And I don't know, I can't really speak to the merging of MRNs, but definitely I've seen this in strange ways that don't make sense. Even with legal changing, I see the, prior names being still used there. And so I don't know if there's someone from IT who could help us. But again, I think UH does need to take the lead to find ways to make this easier, because the tools are at our fingertips and we just may not be aware of how to use them. But then we need more infrastructure. If you go through most of our facilities, we do have gendered bathrooms, and this is a problem. It's throughout the whole hospital. I'd encourage everyone just to take a look around, and if you are ever in a facility where there's gender neutral restrooms, you'll see it's very easy to make those changes. They're usually single use restrooms, gender neutral, or it just doesn't even matter if it doesn't have to be a gender, it just could be a restroom. I think those are simple things that we have the onus as an institution who serves this population and wants to be sensitive and inclusive to make. And I'm sure there's lots of other examples, but we could certainly start there.
Yeah, I would say, even just by example of our gender care services, like we are meant to be embedded throughout the entire hospital system. It's not one single brick and mortar center that's meant to transgender or LGBTQ plus individuals go right here. We're part of the community. They're embedded throughout the hospital system. And that's just one of, to me, an infrastructure decision that was made to be inclusive. And I, like Dr. Pope said, I would agree with just looking for even small, what you think are small changes in your system. So if that's changing questionnaires to be using much more inclusive language on your intake paperwork, if that's, thinking about signs, how you describe your services, I think those are very, very important and relevant.
Yes, absolutely. You're both so correct. It's important as an institution to be able to treat everybody how they would like to be treated. And it looks like, hopefully per Christina, that we're making some movements on some efforts, and we're really working at it. So that is really great to hear. So just to hop back to research a little bit, and that you're working on your research projects now and going to be reporting results. So historically, research results have been reported as binary gender identity. So how is research evolving now to incorporate the non-binary gender identity? Dr. Kelly, I'll let you kick that off.
There's still a long way to go, I believe, but one of the primary changes that has been incorporated over time is the changes in socio-demographic data that gets collected. So being much more inclusive in assessing gender identity, sexual orientation when someone is engaging in research. So making sure that as a researcher, you're not just including binary gender identity on your survey data or demographic information for your data set. So that's incredibly important. And then I think researchers are starting to be a bit more mindful in communicating in publications and presentations about what was actually assessed in the study. Did you actually assess gender identity? Did you actually assess sex assigned at birth? And getting a better communication about that, I think, has been a little bit more prevalent recently. And then I think more of an approach towards this community-based participatory research has been very important in improving research in this area. I would say those are a couple of things that stand out to me.
Perfect. And Dr. Pope?
Yeah, I would just echo that. I think Dr. Kelly answered that pretty comprehensively, but I would just say going the extra mile to be inclusive and ask the questions when it's not otherwise required is important to continue doing. And the researchers will continue doing that. I think as grantors and funders require inclusion, that is the way to make the change, because research usually needs funding to happen. And so I think that's the main way to do it.
I can add, if I can add one more thing. I have the pleasure of sitting on an IRB committee, and we now have, an attention specifically when reviewing protocols to look at diversity and inclusion. And so it's just so nice to see that, that attention is being addressed in a lot of different platforms.
Absolutely. It seems like hopefully as things go on here, we're really progressing and moving forward in this area. So we actually have another chat question. Has there been much research on the LGBTQ plus youth? And what are some of the different challenges that might come from this population? Dr. Pope, would you like to kick that off for us?
Yeah, I mean, I would say research that involves youth of any kind is challenging because of there's extra forms you have to fill out, there's extra paperwork, right? You have to get the parents or guardians to sign on and consent. And so it's tough, but that research is happening. Fortunately, it's not something that I'm doing much of because I take care of an adult population, but that research is happening. It's just always challenging to study minors, I think in any field, but especially in LGBTQ plus minors, because sometimes they are actually not supported by their guardians and their parents. And so if they don't have a relationship, or if they feel like this would be even more challenging to get a sign on from a parent or guardian, that just adds another layer of difficulty. So we should really applaud those who are researching successfully that population of youth.
Perfect. Dr. Kelly?
Yes, I think I would mainly echo Dr. Pope's statements. I don't personally conduct that research, but it's not because I wouldn't want to. I'm just more in the adult domain for research and clinical work. But there certainly are individuals I know in our setting that are doing that work. Very necessary, especially with things going on in the world, decisions being made. So it's incredibly important to give voice to LGBT youth. And as Dr. Pope mentioned, it's just more challenging in research in general because of the minor population are considered a vulnerable population in the context of research. So there's a little bit more steps that need to be made, and it's challenging to navigate with getting parental consent if an individual is not out to their parents or guardian.
Yes, I completely agree with that. So I have just a couple more questions here that I hope we can get through. So one more, what are some of the reasons that you may encourage a patient of yours to really consider or participate in clinical research? And really, how would you approach them about it and really make them feel comfortable about it? So I will let Dr. Kelly kick that one off.
I think probably just touching on what I had mentioned before about this whole shared decision-making model. I'm all about empowering someone to make a decision for themselves. So I don't want to be coercing or pressuring someone to engage in research if they don't want to. But I would talk with someone about like what are their values, what's important to them, and how might engaging and participating in research as a participant really lead them to be closer to their values and engaging in a values-based action. And just talking about a sense of advocacy and being able to really have a space to give their voice. Sometimes I think someone might feel more comfortable doing that in the context of research than doing it in front of their healthcare provider, for example. And so sometimes I might talk about it that way. But again, I try to encourage someone to make a values-guided action towards that.
So I'll just add to that. I do talk to a lot of my patients about participating because I tell them this is another way that they can have their voice heard, and it's anonymous, right? So think we never identify our research participants, but I think we are living in a world of evidence-based decision-making, evidence-based policies, and the only way we can create that evidence is by doing the research and documenting it. And so I really do encourage people who want to have their voices heard and want to see change happen to participate, because it's a great way to affect change in the long term.
Yes, great. Research definitely makes change happen. So that's fantastic. So I actually have one last question for you, and this is an audience question. So what are some tips or resources that you two could provide to help get the conversation and awareness of the LGBTQ plus health disparities out there to really avoid offensive behaviors that could come with it? Right, Dr. Pope?
Yeah, I would direct this back to our gender care program and what is happening through that program throughout the whole system. I know they are offering services for sensitivity training. They will come and meet with your department. Oh, thank you for putting the link there. Or your division, whatever the need is. They are very, very responsive, very kind, and very quick at getting back to you. And they'll help to work with you and your team in whatever way you need them. So I think that's an amazing resource that we have at UH, and everyone should be taking advantage of it. I think that's the best the best thing I can suggest.
I would generally agree and echo that. I think just being very familiar with our gender care services and what is provided there. And I think just approaching this with humility and being open-minded to admit your own mistakes, admit your own shortcomings, admit areas that you are not comfortable with or knowledgeable about, and approach that again from a place of humility, I think is very important.
Yes, great. And just lastly, we all know that involving research, there are a lot of myths and history that goes along with it. So talking about some of the biggest myths about clinical research that you may have heard, in the past, what would you like to know? What would you like people to know to debunk some of those myths? Like, you always hear I don't want to be a guinea pig, or all trials are drug trials. What sort of things would you like to say to debunk some of those?
I could take that one first. So I think people do worry about being guinea pigs. They do worry about having things tried out on them or tested on them. But honestly, we have very strict guidelines with the institutional review boards, and we all have to detail every small aspect of a research study, and it sits before the committee and has to be approved. And there's a lot that's not approved. So there really are a lot of checks and balances that have come into place because of the negative history that we have and because of the abuses that have been made in the past. And so I would say it is a different world of research now. I feel like there's a lot of safety checks, and you can always decide to withdraw if you want to try to participate in something and then you find out more about it, or something doesn't sit right with you. You walk away, and that's part of the research reassurances that we have to make. So I feel like that's a big myth, that people are worried they're going to get locked into something and be made to feel uncomfortable, and then their information is out there, or something strange is going to happen to whatever they like, if they're donating or giving a blood sample or a specimen. But honestly, there are so many safety checks. I really feel like you can feel secure and know that you're contributing to increasing knowledge where there's so many areas where we need more understanding.
Dr. Kelly, do you have anything to piggyback off that?
I would say probably similar to that, like reading an informed consent form, don't just look at it and sign. I think just going in and really reading the informed consent form will describe a lot of the things that Dr. Pope talked about in terms of the risks, benefits, alternatives, withdrawal, any options, and knowing that we want it to be an informed process, and so that they can certainly ask any questions to the study team that they might have. They can ask questions of our clinical research center, of the resources and the foundation of where our research comes from, knowing that they can ask those questions about just learning more about what the checks and balances are, and if they have concerns, who can they contact if something comes up. I think that to make it a more informed and safe space is important.
Yes, absolutely. We like to make the research process as comfortable as we can for people. Well, now that we're getting towards the 1 o'clock time here, thank you all for joining us. And thank you again, Dr. Pope and Dr. Kelly, for really taking the time to talk with us today about your incredible work, the importance of research, and most importantly, the role that research volunteers play in the shaping of medicine. So in the chat, you'll find the information that we dropped in there about our LGBTQ+ and gender care services here at UH. So that is a very great resource for anybody to go and take a look at and know what UH offers. And then please join us for next month's Discover with UH webinar. We will be highlighting healthy vision, and that is on July 28th at noon. So everyone have a great rest of your week and a great weekend, and thank you for attending.